Thank you very much, Mr. Chairman, for this kind introduction. First of all, I'd like to thank the organizing committee, namely Professor Salah Naga and Professor Iman Gouhari, who invited me to deliver this talk about acute kidney injury in elderly. Is it important to study this problem? Yes, because we have a problem with aging. The pace of population aging is much faster than in the past, as shown in this figure. Again, between 2015 and 2050, the proportion of world population over 60 will nearly double, as well as the bad news that in 2050, 80% of older people will be living in our region in low and middle income countries. This figure from the United Nations show that the highest incidence of geriatric population is present in Europe, followed by North America, and Africa has the lowest incidence. In 2050, 1 person in 3 will be over 65. This is huge, and 1 person in 10 will be over 80. So this will add to the a great burden to the healthcare services. As regard the World Health Organization data, it's variable, the proportion of age population all over the world. Egypt have only 8.5% of the general population above 60. In comparison to Italy, for example, it has more than 30% of this population. What about the aging procedures that occurs in our kidney? There are a lot of structural and functional changes occur in our kidney with aging. As regard the macrostructural changes, there are a lot of changes, namely renal atherosclerosis, decrease in the total kidney volume by around 20 cubic centimeter per decade. There is decrease in the cortical volume and decrease in the corticomedullary ratio. There is increase in the sinus fat and increase in the surface roughness and increase in the number and size of renal cysts. As regard the microstructural changes occurring in our kidney with aging, there are arteriosclerosis and arteriolosclerosis. Ischemic appearing glomeruli together with the podocyte depletion lead to the focal global glomerulosclerosis and interstitial fibrosis and tubular atrophy. Consequently, there is decrease in the nephron number, and there is compensatory hypertrophy of the remaining tubules only, and the glomeruli remain stable in size. For the functional changes, there are a decrease in the total GFR by around 5 to 10 millimeter per minute per decade after the age of 40, with an average of 7.5 milliliter. There is stable single nephron GFR because the number of the nephrons decrease. There is stable minimal urine albumin excretion due to the sarcopenia of aging and the malnutrition. There is tubular dysfunction with decrease in the sodium reabsorption, decrease in the tubular potassium transgradient, and defective urinary concentration. There are a lot of cellular and physiological alteration occur in the kidney. Namely, there is decrease in the antioxidant activity and telomere shortening with chromosomal instability and cellular instability and senescence and apoptosis. There is decreased classo expression and increased FGF23 expression and high Wnt signaling pathway, and this promote fibrosis, vascular calcification, and nephrosclerosis. A lot of age-related pathways contributing to the altered renal outcome in elderly, namely the increased cellular senescence, the profibrotic signals, the vascular response with increased sympathetic tone, decreased vascular response to vasodilator, and increased vascular calcification. There is a state of inflammation in elderly and increased oxidative damage. So by the end of the day, we have high susceptibility to AKI. Why elderly people are vulnerable to acute kidney insults? Because they have more comorbid conditions like hypertension, heart failure, and diabetes. They are more user for nephrotoxic medications. The renal functional reserve decline with age, as Professor Salah Naga mentioned last year. There is disturbance in the auto-regulatory defense mechanism to dehydration, and this will lead to ischemia of the AKI and AKI. There is blunted nitric oxide production and cellular antioxidant defense decline with age, with tubular damage lead to more vulnerability to ischemic changes. So the incidence of AKI in elderly is high. It constitutes about 3 to 4 to 8 fold increase in community-acquired AKI in patients above 60. And it was found that the yearly incidence of AKI rose from 17 per million under the age of 50 to more than 940 per million in the age of 80 and above. And this is a U-shaped curve of the incidence of AKI. It shows the rise of the incidence of AKI starting from the age of 60. What about the etiology of AKI in elderly? We have the classical pre-renal, renal, and post-renal, but the underlying causes varies. As regard pre-renal AKI, which is the second most common AKI cause in elderly after ATN, the main underlying pathology is decreased perfusion, either due to decreased cardiac output, as in cardiomyopathy and heart failure, which is common in elderly, decreased effective circulating volume, as in sepsis and cirrhosis, and hypovolemia due to GIT losses, excessive diuresis, and poor oral intake, which are common among our elderly patients. Risk factors for dehydration include acute febrile illness, polypharmacy, namely diuretics and laxative, and being bedridden with poor oral intake. Moreover, this is difficult to diagnose dehydration in elderly because the clinical signs are unreliable in elderly. Again, the traditional urinary parameters that differentiate pre-renal from renal, which are the fractional excretion of sodium and urinary sodium, may simply the physiological age-related disturbance in tubular handling of sodium and water, as well as the common use of drugs like diuretics. For renal AKI, we have numerous causes, but ATN is the most common. We have renovascular disease, hemodynamically mediated AKI, ATN, acute interstitial nephritis, and GN. Renovascular disease, secondary mainly to cholesterol embolism after intravascular procedures or surgery, and rarely the acute renal artery thrombosis. Elderly are at higher risk for renovascular AKI because of they have more atherosclerotic vascular disease and increased need for invasive procedures. As regard to hemodynamically mediated AKI, this is due to direct interference to the protective autoregulatory mechanism of renal blood that maintain the renal blood flow in GFR. And the common examples are the NSAID-induced AKI and AC inhibitor-induced AKI in elderly. For the risk factors for NSAID-induced AKI, we have the atherosclerotic cardiovascular disease, renal hyperperfusion states, and pre-existing CKD. And for the AC inhibitor-induced AKI in elderly, the risk factor is significant renovascular disease as bilateral renal artery stenosis. ATN is the commonest cause of AKI in elderly, and the main cause either toxic or ischemic. Acute interstitial nephritis secondary to medication for associated comorbidity beside the over-the-counter medication and herbal supplements commonly used by elderly people. GN is also common in elderly patients, and the most common encounter types are the ANCA and anti-GBM associated RPGN. The use of immunosuppressant medications like cytotoxic drugs and plasmapheresis in elderly is warranted because of the higher incidence of complications, especially the opportunistic infection, and this will raise the relative risk of this of deaths in such population to 5 times higher than the younger population. This study showed the renal biopsy in elderly above 60 and very elderly above 80, and they found that the biopsied AKI, the higher essence of the main cause of AKI in such populations was a post-immune GN in the elderly population as well as in the very elderly population. This as regard the biopsied AKI, not all causes of AKI in elderly. For the post-renal, the incidence reached up to 9%, and prostatic enlargement and ureteral obstruction due to pelvic malignancy and retroperitoneal fibrosis are among the main causes. The diagnosis of AKI in elderly is somewhat late due to the low serum creatinine in such population, and the rate of serum creatinine elevation is much slower, secondary to the small muscle mass and the poor nutritional status in elderly. The biomarkers of AKI in such population is under research. This is a list of the urinary and serum biomarkers used in elderly. For prevention of AKI in elderly, you have the general approach for prevention. Coming on the top of the list, the avoidance of nephrotoxins, which is very important, minimization of nosocomial infection, extracellular fluid expansion, avoidance of agents that impair renal blood flow autoregulation like NSAID and RAS blockers, and the use of computer surveillance system and e-alerts like as Professor Yasser just mentioned just now. Together with the specific renal protective strategy, for example, in radiocontrast agents, we have to prevent, as in the general population, by using the lower volume of isoosmolar contrast, the well hydration of patients with normal saline, as well as the other supportive like the bicarbonate and N-N-acetylcysteine, which are debatable. What about the treatment strategy for AKI in elderly? The general principles of treating AKI in elderly are similar to those of the other population, but early intervention should be instituted to prevent complication. The initiation of renal replacement therapy in AKI is a controversial issue as regards early versus late, high versus low dose, and the methods of renal replacement therapy. These studies showed that the early initiation of CRRT in elderly provide a better survival for those patients in comparison to the late initiation. What about the outcome of AKI in elderly individuals? We have to discuss the mortality after AKI, CKD after AKI, and functional outcome. As regard the mortality in elderly people following AKI is much higher than that of the young peers, and infection during the course and critical illness are among the predictor for mortality in such vulnerable populations. Other factors that affect the survival of AKI in elderly are the underlying disease, as well as the precipitating factors like heart failure, infection, drugs, and the renal causes of AKI. And this study showed that the renal causes of AKI provide more mortality than pre-renal and post-renal. As regard the non-recovery or the CKD as an outcome, this meta-analysis show that the elderly people have a 28% more risk to turn into chronic renal disease and end-stage renal disease in comparison to the young peer. As regard the quality of life, we have this elegant study which showed that those who are surviving from AKI in elderly have a poor physical component of quality of life, but the mental component is the same, and also the items under the domain of the physical component are all reduced in those patients following AKI. So to conclude, ladies and gentlemen, the incidence of AKI is rising with aging. Elderly patients are more susceptible to AKI. Older people with AKI carry an elevated risk of mortality, CKD, as well as impaired quality of life. Maintaining adequate hydration and avoiding nephrotoxic agents are helpful in preventing AKI in elderly. No proven treatment measures exist for AKI in elderly individuals except for supportive treatment. And thank you.